So thanks for coming, everyone. Today is the day after World Homelessness Day, so I think it's really fitting that we've got an hour dedicated to this topic at the conference today. We've got a really impressive group of speakers here, and I'll introduce you to them in a moment. So just first of all, the aims of today, I want you to understand the challenges that people experiencing homelessness have when they're trying to access physiotherapy. And I want you to understand also, leave today appreciating the holistic value of things like physical activity for this population. And then I hope that the conversations will get you to think about what you guys can do within your services to actually make what we're doing more easy to reach for people who have additional challenges in their life, like no home. So the plan for today is that I'm going to just provide some background to homelessness, the numbers, these kind of things. And then I'm going to introduce Debbie and Aileen, who will be having a conversation about what it's like to try and see a physio when you have no home. Julie is a physiotherapist from Dublin who will be giving you a global overview of physical activity interventions for people experiencing homelessness. And then Fiona, also from Dublin, is going to talk about her interventions where she's been working with people in hostels and day centres with physical activity interventions to try and manage frailty. And then it's going to be over to you. We'd like you to ask us questions, find out from us, answer your questions about your services and how we can move forward. Okay, so let's think about homelessness. First of all, homelessness might mean lots of different things to different people, and I think a lot of people assume that it's people who live on the streets, but actually a large proportion of people who are homeless might live in a hostel or insecure housing. So just to give you the kind of rigid definitions of homelessness. People who are roofless are people who we might see sleeping on our streets or who use night shelters in churches but spend the day in public spaces. People who are houseless might be people who are living in hostels or refuges. Insecure housing would include people who might be in supported accommodation, but that accommodation is dependent on things like sobriety and fitting in with the rules of that accommodation, so it can be really precarious. Then we've got inadequate housing. So historically, inadequate housing was possibly less of a homelessness issue in the UK and more relevant to lower income countries where shanty towns exist. However, vulnerable migrants who are being placed in places like hotels where it's very difficult to support a family when where you have no cooking facilities, things like that, I think you could argue that's inadequate housing. So here's some numbers. The figure of 309,000 people were homeless in England when the last government figures were published in December last year. And just in the space of me applying for funding and it being now, which was only 2 years ago, that number is 30,000 greater than it was a couple of years ago. So homelessness is without question increasing in the UK. Now, if you cast your mind back to the pandemic, we've also been hearing about that today from Michael Rosen. It was estimated that about 5,000 people would need support through the Everyone In campaign to be housed when we were being told to stay at home. What actually happened was that by March 2021, Everyone In had accommodated over 37,500 people. So that shows how kind of grossly we underestimate the size of the homelessness problem in the UK. Similarly, in Ireland, there's a lot of people homeless, 14,500 people, and that has risen 14% in the last year. And nearly a third of those people are children. So we're talking not just about vulnerable people in precarious situations, but a lot of these people are really, really young. Okay, so moving on to homelessness and health. What do we know about people who have no home and their health? We know that they tend to die early, so the figures you might have heard earlier in the ARMA session this morning, people experiencing homelessness are, if they are on the street, the average age of death for a man whilst homeless is 46, and for women it's even younger, 43. Now, obviously, that's not to be confused with life expectancy because that figure doesn't include people who manage to move out of homelessness, but still it's a shockingly young figure, and we must pay attention to that. Also, homelessness is characterised by a trimorbidity of health. So, physical ill health, mental ill health, and drug and alcohol problems. And commonly, these three issues intersect and kind of feed off each other to create further problems. We also know that people experiencing homelessness experience really difficult challenges accessing health, whether that is because they have no address, they have no ID, it's difficult to register with a GP, or whether their life circumstances just make it really hard to get to an appointment or receive an appointment letter. And also, even if people do manage to get to that health service, the stigma that they might experience when they cross through the front door of A&E, or whether they turn up to an outpatient clinic, or when they're in hospital. So even if people do manage to reach our services, are they being treated well? Now, this slide just helps you understand how bad health problems can be amongst this population. So you'll see that the blue bars are the index of multiple deprivation. So the paler bars are people in more wealthy areas, and the darker bars of blue are people living in less affluent areas. Now, the red bar is people who are experiencing homelessness. And as you can see, so look at asthma, look at COPD, there's almost 5 times the prevalence of COPD in people who are experiencing homelessness than the most deprived people in the UK. I mean, isn't that shocking? And these are people who are struggling to access the health services that they need. Now, I did some work, it was quite a small project a few years ago, where we looked at people's access to physiotherapy, and we identified people who were enrolled in a GP practice for people experiencing homelessness, and we tracked their referrals into physio and then what happened to them. Now, first of all, in a 9-month period, we only found 25 people who were referred to physio. And of those people, 9 didn't attend their first appointment, 7 did attend one appointment but didn't come back, and only 4 still had treatment ongoing, and 5 completed treatment. So the stats weren't great. So why is that? What is it that's going on? Is it that people can't get to physio in the first place, or is it that when they come to physio that their experience isn't particularly useful, so coming back isn't a big priority for them? But we know there are some areas of good practice. We know that there will be some mainstream NHS services out there that are inclusive and that are really working hard to try and meet the people's needs that they serve. There are some physiotherapists working in GP practices for people experiencing homelessness, but I know they're doing half a day a week, or their contract is temporary. There's people in Leicestershire, Brighton, the southwest of England. We also know that there's been physiotherapy-led clinics. Manchester Met I met a student who had a poster yesterday. Leeds Beckett have got a clinic running in a church-run soup kitchen. And Cardiff have set up walking groups for people experiencing homelessness. And we've also got Crisis doing Crisis at Christmas, which is a sticking plaster that provides a service for 1 week of the year. So it's something, but it's not solving the musculoskeletal problems and respiratory problems of this population. So that's enough from me about what we know so far about this population and physiotherapy. What I'm going to do now is hand over to Aileen and Debbie. So if you come to the stage. So Aileen is a physiotherapist who I used to work with in Glasgow in a health service for people experiencing homelessness. And now Aileen works in a part of Glasgow that still has many people in houses, but is a very deprived part of the world. And Debbie is we're privileged to have here is a person with lived experience of homelessness and of seeing a physiotherapist whilst she was homeless. So I think she's got a lot of insights for us today to share. Thank you.
Thanks, Jo. Thanks, Debbie, for joining us today. So today, really, what we want to do is just hear from you what your experiences have been and what we as a profession can do to improve on what we currently offer. So in the past, you have told us that when you were homeless that you were referred to physio, and you've had both good and bad experiences with that. Can you tell us a bit more about that, please?
Yeah, sure. I've got a recurring problem with the knee. It's aching now, actually. So if you can give me some physio in a bit, I'll be more than happy. But yeah, the first appointment I had, it was a non-negotiable date and time. You've got to be there for this appointment, or you're going to be struck off the list. So it was 9 o'clock on a morning. Now I was on the streets. The day centres don't open till 9 o'clock anyway. So I didn't get a chance to have a shower, get some clean clothes. I stank to high heaven. If I could have moved away from myself, I would have. You know, the smell of me was that bad. And the woman that I saw, she's, you know, She's as far away from me as she could possibly get trying to do this physio, trying to examine my knee. I felt totally degraded, you know, embarrassed, you name it. And, you know, it was a horrible experience. But when it came time to get the second appointment, they let me choose the time. So I got an afternoon appointment, turned up, smelt nice, had clean clothes on, all the rest of it. You wouldn't have known I was homeless to look at me. And it was a different person. It was a guy that saw me. And he just treated me like any other patient. Now, all we want as people who are homeless is to be treated like any other patient. You know, that's all it takes, just a little bit of common courtesy. Hello, how are you doing? You had a good day?
Absolutely. And I think that's definitely one thing that we've heard throughout the day today as well, that it is so important to give you time to hear your story as well. And I think it was Jane this morning, that if somebody turns up 5-10 minutes late, that not to turn somebody away, because the effort to get to an appointment, the cost, both time-wise and financially, to get to an appointment can be quite challenging. And if you turn up 5-10 minutes late because the buses didn't sort of work for you, or the trams didn't work for you, it's not entirely your fault, but you've still made that personal effort to get there, and to be turned away because, oh, you've wasted our time. But then equally, I know myself, my clinics run late, and I can often be maybe 5, 10, even 15 minutes late, depending on what the day's faced. So why is that any different than you turning up a few minutes behind that allocated time?
I think it's because you're the professionals and we're nothing. It's the same for any patient, you know, they don't have to be homeless, they don't have to have a drink problem or whatever. Buses do run late. You know, I've turned up 5 minutes late and been told to go away. But then, as you say, I've sat there for half an hour waiting for an appointment thinking, you know, what's going on here?
Yeah. Life happens sometimes, and it can be very, very difficult to keep precisely to the clock. When you did get the physio, when you've been in at your appointments, did you find that the physios took into account your situation, access to exercise equipment or space available for the exercises that were prescribed to you?
Not at all. I mean, I was told to go to the gym and exercise. I can't afford the gym. I've got COPD and various other problems, so I can't do the exercises that they were prescribing me to do. And when I mentioned that, oh, go down the park and use the free stuff, you know, the exercise machines in the park. Well, they've all been vandalised and they're rusted up, so you can't use them anyway. And even if you're trying to use them, you've got the little kids running around laughing at you, taking the mick.
It's put more barriers in the way, isn't it? There's do these exercises, but you don't have the space. Go there, but then you feel even more of a fraud because you've got the kids that are trying to get on, or as you say, and it's not just in this area where the equipment's broken, that's a nationwide thing. When you were accessing physio and obviously your other health appointments as well, do you feel that health professionals don't give you time to have your story heard? Do you feel as though you're being rushed, or do you find that they want that information and no more?
Yeah, I mean, a lot of the time it is very rushed. I'm very lucky with my own GP, for example. She's known me a long time since I was on the streets, because she was part of the health inclusion scheme. So she always makes me a double appointment so I can sit and talk to her. But if you get somebody in that doesn't know you, you know, if it's somebody you're seeing for the first time, it can be extremely hard. Just building up the trust. You know, I've known my doctor a long time, so I know I can trust her to do what is right for me. But if you're going to see a physio for your first appointment, they don't know who you are. They've never met you before. They don't know anything about you. And you were telling us a story just there about you saw somebody for 3 appointments and didn't actually do any physio work with them because they just wanted to sit and talk to you. You have to build that relationship up.
I think that's very important when you have got somebody that's got a lot of life that surrounds them, whether it's an addiction, whether it's a psychological problem, whether they've had childhood traumas. We as a profession have to be very much mindful that we don't just have an OA knee coming through the door. We have a person who's experiencing knee pain, and we need to make things relevant to their life and their experiences at this time. I think when we spoke as well before, that we were talking about language, and not only the language that we as professionals use, but not to necessarily be offended by words and language that you potentially use, or the language of the street as well. Is there anything you want to share with us about that in particular?
Yeah, I mean, the language you lot use, a lot of it we don't understand. When you're talking about this muscle and that muscle and what have you, and giving it the proper names for it, it's like, I don't know what that is. What is that? And you feel embarrassed to ask. So then you go away and Google it. And Google gives you the worst possible answer you can get, you know. You've got a pain in your knee, you've got cancer. Oh, no. As for the language we use, the patients use, just because I say, oh, for fuck's sake, it does not mean I am swearing at you. I'm swearing at the situation, my lack of control, my lack of ability to do what you're asking me to do. You know, it's just common language, especially these days.
I think people are exposed to it more throughout social media, and healthcare professionals can't be offended because we find it hard enough to modify our language when we're talking professional matters. So why would we expect patients coming in to change their language when they're in a very nerve-wracking, stressful, awkward position potentially for them as well? That leads me on to really my final question, talking really about do you find that there's a stigma towards people with addiction or experiencing homelessness when they access healthcare?
Oh, definitely. I mean, I'm 5 years clean now. You know, drink and weed were my problems. So I've gone in there stinking of alcohol and weed, and they just don't want to know you. Even the other patients sat in the waiting room move away from you. But for me, it sort of snuck up on me, the addiction. 1 week I'm fine, the next minute my friend's dying of an accidental overdose, and I realise I've got to sort myself out. Otherwise I'll end up in the same situation. But it's very, very difficult to accept the fact that you've got a problem to begin with. Yeah, admitting to yourself, yes, I do have a drink problem, is a very, very hard thing to do. So you're not going to just admit it to somebody you're seeing as a physiotherapist 3 or 4 times. I think so long as if I went in and I'd had a can or two just so that I could function, that shouldn't be a problem. If I went in and I'm falling all over the place and knocking your medical instruments and what have you about, then yes, it is obviously going to create a problem. But so long as our counsellor used to say, need, not greed. Yeah, just have the amount that you need to be able to function in that moment, but don't go over the top.
I think that's really important, because if you're asking somebody to completely abstain from drinking, it can actually be more harmful, and again, putting more barriers in place to providing safe, effective healthcare for somebody. We were hearing earlier about making every contact count, and yes, we can counsel about alcohol intake, physical activity, but it has to be relevant to the person that we've got sitting in front of us, that the one story, the one message doesn't cover absolutely everybody that we've got coming through. And I think certainly what Debbie's saying today is similar to the experiences Jane was talking about this morning. And both Jane and Debbie today are really highlighting a lot of these findings that ARMA have found within their inequality studies over the last few years. And I think it's very, very important that we, as a profession, take that on board and don't try and just create a one-size-fits-all for everybody.
Yeah, definitely. It's about equity these days, this what they talk about, isn't it? Not equality, not treating everybody the same, but making sure it is fair for everybody.
Absolutely. And I think we need to keep that on board. Thank you. Thank you very much for coming along to talk to us today, Debbie. Thank
Pleasure.
you.
Thanks, Debbie and Aileen. That was excellent and really insightful. Important to hear kind of close up exactly what is going on for patients on the other side, on the receiving end of our care. I'd like to move on now to introduce Julie Broderick from Dublin. Take the stage, please. And she is going to be sharing with us the findings of Mixed Methods Systematic Review, which looked at physical activity interventions for people experiencing homelessness. And if I may, the study came about because we were interested in recognising that physical activity interventions are out there for people experiencing homelessness, but actually how effective are they for managing health? So Julie will share that with us now.
Great, thanks Jo, and delighted to be here with you today. So I'll tell you a little bit about our Mixed Methods Review. This was published in January of this year in the British Journal of Sports Medicine with a corresponding blog published. So first of all, why did we decide to do a Mixed Methods Review? The reason is that really a preliminary scoping review revealed that published literature in this field comprised of both qualitative and quantitative research. Therefore, a mixed methods systematic review was adopted. This allowed for the findings of effectiveness, the quantitative evidence, and participant experiences, the qualitative evidence, to be brought together to facilitate a broader experience of whether and how interventions worked. Oh, sorry. So the aim was to summarise the available evidence for physical activity interventions that were intended to improve health outcomes of adults with experience of homelessness. So we focused on two aspects, the modes of physical activity interventions and their effectiveness for improving health outcomes. So what we do and how did we do it? So we were a team of 3. We worked with a dedicated librarian on search terms. We used the ethos definition for homelessness, which includes rooflessness, houselessness, living in insecure or inadequate housing. We made a kind of a tough decision to select high-income countries only. The reason for this is that there's a certain homogeneity in health and social care infrastructure and similarities in family and community support systems. And these really significantly impact how homelessness is perceived and managed. Therefore, this decision was made. So physical activity interventions were included, including those where physical activity was delivered as a standalone entity and also where physical activity was delivered as part of a multimodal package of care. We included all health-focused outcomes. So how did we identify the evidence? We initially found almost 14,000 records. After completing the steps outlined here, in the end we found 18 reports of 17 individual studies which were quality assessed using the JBI family of quality assessment checklists. What did we find? We found 17 studies. Geographically, 5 of these studies were based here in the UK, 7 were from the USA, 2 were from Australia, and 3 were from Denmark. 6 were quantitative and 11 were qualitative. What about the interventions? So they were quite diverse, included 1 cycling intervention, 3 outdoor adventure interventions, 7 soccer studies, 1 gardening, 1 running group, 3 indoor group exercise interventions, and 1 included a pedometer with step count goals. So as the physical activity programs were quite diverse, we collapsed them into broad categories of soccer, group outdoor exercise, group indoor multimodal exercise, and individualised multimodal interventions. So as I mentioned, soccer predominated with 7 studies, and this really wasn't surprising considering its global resonance. In terms of the quantitative study, I suppose of note, there was only 1 RCT, there were 3 quasi-experimental studies and 1 observational study. In terms of the qualitative studies, we use the JBI tool, as we mentioned previously, and also the Conqual tool, and we rated these studies as either high, moderate, low, or very low quality. And interestingly, we found that the majority of qualitative studies were of high quality. In terms of what we found a reasonably solid body of evidence. Across the 17 studies, there were 416 people experiencing homelessness and 38 staff. The age range of participants was between 16 and 65 years. The 16-year end of the age range was really something that was a protocol deviation. And we made the change from including the age of 18 up to and decreasing it to 16 because 5 of the studies included participants from the age of 16. So we made a pragmatic decision based on this then to kind of decrease the age limit to 16. The types of accommodation of participants was quite varied. We did find that a number of studies didn't really define well what type of accommodation their participants were using. We had 5 women-only studies, 5 men-only studies, and 7 mixed cohort studies. So really it was a fairly high representation of women within the whole studies because generally men are more highly represented in homelessness figures. So in terms of what we found, in summary, we found physical health benefits, mental health benefits, benefits to participants' wider lives. However, we also identified some challenges to participation that were associated with being homeless. So I'll just delve into those in a little bit more detail now. So in terms of the physical health benefits, these benefits were found from both qualitative and quantitative evidence. And we found improved body shape or self-image, improved physical condition. It made people more active and improved some blood markers. So this is really what we found with the quant. In terms of the qualitative, again, there was agreement between, in terms of mental health benefits, there was agreement between the qualitative and quantitative evidence. We found that physical activity facilitated self-development and ability to cope with life situations and resulted in generally feeling better from a mental health perspective. We found qualitative-only evidence for benefits carried into participants' wider lives. So, for instance, development of interpersonal skills, improving social connection, moving towards a healthier lifestyle, and just general kind of enjoyment from the programme. So I guess these are quite a lot of nice positive results, but we have to kind of caveat these with that many of the studies didn't specify the dosage. Only 1 study was an RCT. Feasibility outcomes weren't well described, like adherence, retention, and of course we included high-income countries only, so the transferability of results into other settings isn't very well known. Also, some studies did include additional components like counselling, food, sports kit, and we don't really know if these additional components to the physical activity diluted or enhanced the effect. In terms of the challenges found, interestingly, there were some challenges identified, and these mainly centred around potentially stress of participating in tournaments, such as some of the soccer studies were actually tournaments, and participants in the qualitative studies around this topic there was kind of a theme of stress and the pressure to perform in those kind of situations. So that's something to consider. So take-home messages. Physical activity interventions conferred some positive physical health benefits, mental health benefits, and some translation to wider life. So kind of, I suppose, taking it to the next step, it's really build it and they will come, make the programs interesting, make them diverse. But we do need more research on optimum programming variables and strategies to increase adherence. Also, this review kind of underlined the value of the qualitative research, which was generally of high quality and really added to the evidence base in this area. Also, the diverse study designs should be considered, and including, as I mentioned, qual and quant where possible when evaluating these interventions in the future. Final point is that soccer predominated, and we know that soccer is quite a high metabolically demanding sport, especially if it's competitive. That would be about 10 METs in terms of metabolic requirement, about 7 METs if it's more casual soccer, and really the threshold for participating does generally require a certain amount of fitness. So some of the studies wouldn't have been suitable for people with a lower level of fitness. And I think that brings us nicely to Fiona's work, which is an intervention which really targeted frailty in people experiencing homelessness. So thank you, everyone.
Thanks, Julie. That's great. And I just want to highlight that study was actually mentioned in the keynote speak session at the International Olympic Committee, where they're recognising that health inequalities is something that even the Olympic Committee need to pay attention to. So that's really powerful to think that people are taking notice of this topic. Okay, so moving on, thank you, Fiona, taking the floor now. Fiona is going to tell us about her much more kind of hands-on, on-the-ground work, working with people in Dublin who have experience of homelessness and who are participating in various different physical activity interventions that are aimed at managing frailty. Thanks, Fiona.
Thank you. So this research focused on exploring the impact of physiotherapy-led interventions to address physical function and frailty in people experiencing homelessness. Preliminary research from 2018 and 19, which examined the physical function of people experiencing homelessness who were admitted to acute care in a Dublin hospital, demonstrated poor physical functioning and high levels of frailty. In this study, just over 1/3 of participants with a mean age of 47 years used a mobility aid. Over half self-reported at least one fall in the previous 6 months. 38% could not complete a 6-minute walk test, and almost 1/3 could not complete a flight of stairs. So the early manifestation of geriatric syndromes in this young population demonstrated the need for intervention. So the follow-on intervention studies were named the LEAP studies, LEAP standing for Low Threshold Exercise and Protein Supplementation. The approach was based on the ethos of inclusive healthcare delivery to meet the needs of socially excluded populations, such as people experiencing homelessness. Our approach was low threshold, so we met people where they were at, with minimal barrier to entry. In a regular or mainstream system, for example in a physio department, we see a system of scheduled appointments, and ingestion of substances would be a barrier to entry, as Debbie alluded to. The LEAP programs were drop-in, and the ethos was, come as you are, whatever the stage of your addiction journey. It was trauma-informed, with awareness and understanding of past trauma, and with empathy superseding the need to meet targets. It was flexibly delivered and tailored to facilitate inclusion and maximum participation. It was multimodal to target physical function and frailty and to meet physical activity recommendations, and also to offer choice. And it was fun, using self-selected music, having laughs and casual conversations, as well as brief informative interventions on physical activity and nutrition to educate, improve health literacy, and to encourage healthy lifestyle choices. So the LEAP-1 study was a feasibility intervention study, and this took place in 2022 in a low-threshold open access day service in Merchants Quay, Ireland, for people experiencing homelessness and addiction. So it involved a once-weekly multimodal exercise programme with protein supplementation in the form of 20 grams of protein in a 200ml shake called Fresuvan. It was delivered for 16 weeks, and it was a rolling programme, so people could join in at any point over the 16 weeks. It was delivered with minimal equipment, including weights and therabands, balls, steps and ladders, and it took place in a small room in the centre. And we used a test battery to evaluate physical function and frailty, and this was informed by the preliminary study. So it included the short physical performance battery, hand grip dynamometry, pain rating, the mini nutritional assessment, the clinical frailty scale, and the share frailty instrument. The exercise intervention was one-to-one due to the limits of the space in the centre, but also it was a setting where people preferred to exercise alone. And as a safety precaution, blood pressure and heart rate monitoring was conducted for all participants in all programmes. So 31 people took part in Leap 1, and the mean age was 45 years. The majority of people had poor physical function and frailty. The short physical performance battery showed that 66% of the group scored less than 10, so this was indicative of one or more mobility limitations. 77% scored below the normative mean value for grip strength, and the mini nutritional assessment highlighted that just under half were at risk of malnutrition. Pain was prevalent in just over half of the cohort, and frailty and pre-frailty was relatively high using the clinical frailty scale and the share FI when compared to data in older people. The higher CFS frailty score may be attributed to the fact that it focuses on the many dimensions of frailty, whereas the share FI, like the frailty phenotype, assesses the physical domain of frailty. In terms of feasibility, higher retention was observed in older participants and also in women and those with more stability in addiction and housing. Adherence to the programme was high, safety was demonstrated, and in terms of acceptability, the feedback was overwhelmingly positive. In terms of effectiveness, no statistically significant effect was seen as a result of the intervention, and we felt this wasn't surprising data considering the once-weekly nature of the programme and its pragmatic design. So overall, with the evidence of feasibility, this study demonstrated proof of concept. So Leap 2 was an enhanced low-threshold programme based on learnings from Leap 1. It was a 12-week programme delivered in 2022 and 2023. The setting was a day service for people with chronic addiction issues, and many also experienced homelessness. This programme involved prior stakeholder engagement to facilitate a co-designed programme with input from service users and staff in the centre. So as a result, Leap 2 involved 3 times weekly exercise programme. It offered 2 exercise classes in the form of a circuit and a park walk each week, and it delivered one-to-one group and women-only classes. The test battery of physical function and frailty outcomes changed slightly from that used for Leap 1, as a ceiling effect was found in the short physical performance battery for many participants with higher levels of function. So it was replaced by the 10-metre walk test, the 2-minute walk test, the chair stand test, and the single leg stance test. And the short form 12 was added as an overall measure of health status. And Leap 2 also conducted exit surveys. So we had 43 people participate in Leap 2. The mean age was 47. Results from the test battery demonstrated notable subnormative physical function values. Pain was common, and high levels of frailty and pre-frailty again was found using the CFS, and to a lesser degree using the share frailty instrument, explained by the multi-dimensional focus of the CSF, detecting something beyond physical frailty. Overall, these 2 frailty instruments were found to exhibit complementarity through their distinct attributes and findings. While regular attendance was low, feasibility was demonstrated by high retention in the same subgroups as Leap 1, the older, the females, and more stable participants. Adherence to the exercise and protein supplement was above 90%. Safety was demonstrated in the absence of adverse events, and acceptability was demonstrated in the post-programme feedback. Pre-post intervention results demonstrated improvements in a number of physical function outcomes, pain and frailty in the regular attenders. So as evidence shows the need for gender-sensitive interventions for socially excluded women with complex needs, as well as evidence that women adhered well in Leap 1 and Leap 2, Leap W, a women's-only 10-week programme, is delivered this year. Leap W was based in a women's-only centre, Jane's Place, a safe space where the women attended for healthcare and support services. Leap W was a mixed method study. It also had prior stakeholder engagement, and it conducted one-to-one semi-structured interviews following the interventions to gain a deeper insight into the views of participants and the impact of the intervention. This programme had a focus on women's health, so following the main exercise circuit, a core stability and pelvic floor set was performed by the group. So 33 women enrolled in Leap W with a mean age of 41, this group, so it was lower than Leap 1 and 2. And again, the group was key to engagement, motivation, and the camaraderie that was seen to develop over the course of the programme. similar to findings in the systematic review that Julie discussed. On the other hand, some people appreciated more one-to-one time, and this was also facilitated. Notable levels of poor physical function and frailty was observed, again using the same test battery as LEAP 2. High levels of frailty and pre-frailty were found, and notably in this study, the frailty scores by the two frailty tools were closer to each other. Again, feasibility was demonstrated by a high rate of regular attendance, safety of the programme, and high adherence to the exercise and protein. Acceptability of the LEAP W programme is evident from the qualitative data, and many people expressed a strong desire for the programme to continue in some shape or form. Pre-post intervention effectiveness was demonstrated by improvements in almost all the physical function outcomes in the regular attenders. But there were many challenges and many reasons for low retention, and these were common to all programmes and common to engagement in low threshold services in general. There were chronic, long-standing addiction issues in the majority of participants, also mental health issues and a dual diagnosis of mental health and addiction issues in many, and much was attributed to past trauma. And as a result, motivation levels were fluctuating. Unstable housing environments, including hostile accommodation, rough sleeping and sofa surfing, led to chaotic lifestyles and often with sleep deprivation and competing priorities, and understandably exercise was way down the list and survival was at the top. Health literacy appeared to be low in many, and the poor physical health that people experienced often was viewed as a barrier to exercise rather than an opportunity to improve health. Some cases of conflict among participants within the group affected the dynamic at times. However, flexibility and the one-to-one work helped here. A theme of low self-esteem and self-worth emerged from the qualitative data, where many people didn't feel deserving to feel good or look after their health, and this often prevented them from engaging even though they enjoyed the programme, and there was intent to return. So finally, impact was demonstrated by the feedback provided by all the LEAP programmes, and here's some of what was said, really highlighting the mental health impact of the programme. Following LEAP 2, the park walk continued, and a number of the female participants went on to complete the Dublin 10K Women's Mini Marathon in 2023, and again this year, which was a massive achievement for these ladies. And then following LEAP W, exercises also continued, with the fitness instructor delivering once weekly classes in Jane's Place, and these are based on the LEAP W programme. So this is really good news, demonstrating immediate impact for this marginalised population. The low threshold, flexible and trauma-informed approach is considered key to successful delivery of physiotherapy-led programmes, and it's seen as a bridge to mainstream services, which many people find so challenging to navigate. A limitation of this research is the small sample size, but as a novel concept in this field, it's felt that this work adds value to the evidence base. While changing the physical status of people experiencing homelessness, addiction and mental health challenges won't solve everything, the value of this intervention for physical and mental health needs to be recognised, and it's really such a positive focus from which there can be a ripple effect in outcomes. Thank you.
Thank you, Fiona. Okay, so we've kind of raced through some really important discussions and heard from our excellent speakers. So now it's open to the floor. I'd really like this to be kind of an interactive discussion, both with people online and people in the room. So I think we've got some roving mics. If anybody has questions, pop your hand up. I can see Jane in the audience there. Yeah.
Thank you. That was really interesting and a really important topic. It's a question for Debbie, if that's okay. I'm really struck by your initial experience of going to a physio department when you said it was 9 o'clock in the morning, you knew you smell or whatever, or maybe you'd had, you smell of alcohol as well, and you didn't have a warm reaction from the physio. I just wonder whether you've got any advice for us about how we should broach that topic if we have somebody in front of us who, clearly is struggling. I think often people don't know what to say or how to broach the subject. So any advice would be really helpful.
You don't need to say anything special. Just treat people as you want to be treated yourself. It doesn't matter. You might have had a rough night the night before and come in smelling of alcohol. But we as a patient can't say anything to you about it, so why do you need to say it to the patient?
Yeah, thank you. I suppose what I was getting at as well, though, is I don't know, do we have a duty of care to try and broach the holistic issue that's going on rather than just your knee, like you've said about, we're not treating someone with a knee problem. It might be obvious that there are other challenges, and we want to try and make every contact count and signpost to maybe other services that you might not be accessing. That's kind of what I was getting at more than anything, I think.
I think, yeah, I mean, that'd be great. If you feel confident enough to do that, that's brilliant. But don't be surprised or upset if somebody tells you where to get off. None of your business, If that person wants to speak about it, then brilliant. But just don't be surprised if you get told where to go.
Okay, thank you.
Question up at the back there. A roving mic having to run.
Hi, thank you. Thank you all. I just wanted to understand what you meant by trauma-informed for physiotherapists a bit more, please.
So it is what it says. It's just being informed of and understanding that people have a story, a backstory, and it could be traumatic. So just to, consider that the way people present themselves, behave and react sometimes, there's a reason for it, and to try and understand that, and maybe rather than be defensive, maybe be curious and ask them how they are. Or even like the last question, I think it's important, someone said it this morning too, just, when we're setting goals, what matters to you most? What goals do we need to set, with this person in front of us, and just understand a little bit more about their needs. But it's just being aware of their story.
Thank you. I think I was wondering if you'd got some training or a specific something that you'd done. I'm thinking of our department and thinking people would handle that. That would mean very different things to different people.
Yeah, there's a whole body of literature around trauma-informed care and trauma-informed practice, so it might be worth exploring that and trying to kind of understand adverse childhood events and how those can influence, I suppose, reactions to certain situations and triggers as well, that sometimes considering that you're the power imbalance there sometimes, and that you're perceived to be in a position of authority, and how that can be a threatening kind of signal sometimes, and the impact of that. So I guess we've all a different perspective of that, but not personally, but just reading around it and going to not specific training, but I guess informal training on it, I would say, and reading around it.
I could probably add, if you Google the homelessness and health charity called Pathway, they're an organisation that basically their main focus is to support people experiencing homelessness navigate healthcare services. And on their website, there's quite a lot of resources and information, including work by John Connolly, who's a psychologist who's done a load of work on trauma-informed care. So, I mean, I haven't specifically read what resources are on the website, but I would imagine that's a really good place to start to find out about how you could perhaps run an in-service training on this if you were to read around it.
The Groundswell website as well.
Yeah.
I've got a lot of information.
So Groundswell are a homelessness community-led charity who, again, support people with experience of homelessness to get involved in research and advising healthcare services. They've done a lot of really good work in respiratory care and dental care, in well-being, and collected data from people experiencing homelessness. So again, if you look on the Groundswell website, you'll find some really useful stuff.
NHS Scotland has also got a training package on trauma-informed practice, and I believe they've actually used videos that were produced by one of the Welsh NHS trusts. So there is some NHS specific training out there as well on the matter.
I was also going to comment that I'm a mental health physiotherapist, and we deal with traumatic, patients with a lot of trauma often. So CPMH, so the Chartered Society of Physio and Mental Health, may be able to help with some of that. And I think they've got a stand here today with their lead on it. So you could maybe find them and go and ask Lauren if she's not here already. I also have a question. So in mental health services, I'm beginning to see that we have quite a lot of women, and I suspect it already, but in my service, I'm finding that I treat more women than I do men, and I'm across equal wards, 9 wards, and I believe that we have more falls risk through it, which would fit in with your frailty. And I'm just wondering whether you notice that in your service, because although there are more men than women, did your female population, did they have more risk than the guys? Just because physical activity is so much, there's less physical activity in women than there are men generally in life.
So is this a question for Fiona?
Anybody.
I suppose in my 3 interventions, we didn't look specifically at falls risk, so I couldn't tell you. I'd have to look at the data.
I suppose it would also be around frailty, wouldn't it? Because it's about strength.
Yeah,
So it would be in LEAP as well. It would be in any of them, really. I'm just wondering whether you saw it like I'm beginning to see it when I'm looking at my data now. So I
think in the first study we did, the cross-sectional study that Fiona talked about first, it wasn't strong enough to be statistically different, but there was kind of a hint that women were particularly prone to more geriatric syndromes and earlier aging, and I suppose it was that, but also the women in those interventions, they were more receptive to coming back. They engaged better, with better retention with that group as well. So it seemed like they needed it a bit more, but they also enjoyed it more and were more receptive to it. So it was.
It just fits. I'm a physical activity clinical champion, and so I know about the data around physical activity, and it just seems to fit with what I see in mental health services, and then I wondered. So when you're thinking about your caseloads, as in every situation, really, we're thinking about our females, and there's actually with in non-binary as well, is how they access physical activity, and then you put that into the homelessness population too, and you begin to see how much of an effect that has. And that was one of the reasons I've come today, was to find out about it. But thank you, it's been brilliant today.
I could possibly add a little bit about women's health. So I'm looking at frailty in people experiencing homelessness with a PhD I'm doing at the moment. And what we found is that we're finding prevalence of frailty sky high in the population, and amongst women it's worse than men. But clinically, when I worked with Aileen in Glasgow in a homeless service, I would say the patient group that was very representative of the proportions of men and women, and the majority of people we saw clinically were men, weren't they? Absolutely. And we know a lot of the people who are the hidden homeless, so people who are not known, haven't gone to the local authority looking for housing support, are women because maybe they're staying in abusive relationships, so they're in insecure, vulnerable housing situation, but they're not known to services. So their health is becoming more and more problematic. They might be, being assaulted, so that their physical well-being is deteriorating, but people don't even know that they're there and they're not being counted.
Hello.
There's a voice. You're there.
Sorry, I just didn't know it was the time to move on. Sorry.
Yeah, go for it.
My name's Paul. I work in prisons.
Hello.
So I see a lot of the people that you've been speaking about. And I sometimes feel this is probably true in all of our settings dealing with this group of people, but in prisons especially, we've got all the time in the world and no time at all. And I think from all the sort of themes that have been coming through, where trust is becoming such a big thing about how we gain people's trust, where's the time coming from for that? And I guess that's my question to the panel. We seem to be under more and more pressure on waiting lists, and the time is not there to grow that trust. I just wonder what you thought about as a profession, how we fight for that.
I feel that's a good question for you, Aileen. Disruption.
Absolutely. A really good question, because, as you say, the pressures are there to get through. The patients don't have them on your list, discharge, outcome. And if we can't get a good rapport built with the patient on the first visit, then you're never going to get them on board to take their exercise programme, make the necessary health changes that have become evident. And I personally find that with a lot of people, I don't even get onto an objective assessment in the first visit. I would rather spend the time, recognise and find out more about them, their needs, and be able to even just ask them to make one small change before I see them the next time. And I find that personally my fail to attend rate isn't massive, it's quite small, and patients appreciate being listened to, not being overwhelmed by an exercise programme that is completely unrealistic for them. They can do it within the house, they can do it if they do find that they've got a few minutes during that day. And very often I say to people, a little bit of something is much better than a whole lot of nothing. So if they can just make one tiny little change for a few minutes a day, it's better than being overwhelmed and being unable to achieve anything at all, adding to that feeling of failure that you were speaking about earlier as well. And I think sit back, listen to the needs of who's in front of you.
I think we've got time for one more question because I want everybody at the end to think about take-home messages. So let's have one question and then we'll finish with that.
Thank you very much. That was great presentation from everybody. I'm really glad I came to this session. My question was, I was wondering if any of you have become more involved in policy development from whatever perspective.
I certainly would like to, but haven't. Debbie, have you got involved in policy development?
No.
Because I think it's people like you who are the most important people to get involved in changing practice and policy.
Not in healthcare, but I've been part of the Rough Sleepers initiative in Salford. So we've helped write their 5-year plan.
Right. And that's so important. And what about you guys?
Like, doesn't feel directly, but then surprisingly there's software where you can find out your papers where they're quoted in policy. And actually probably anybody who's written a paper should run this software. I can link anybody with it afterwards. And it's actually quite interesting to see that actually sometimes you don't realise it, but it's your paper then is quoted in a policy document in New Zealand or Germany or, you know, around the world. And you'd be surprised where your paper or your conference presentation can be quoted in policy. But you don't even know it. So that can be nice. But I feel with us, it's kind of hard to directly make that link to local policymakers. I'd like to be better at it and know about how to do that better, I guess. Yeah.
And if any policymakers are in this room, please speak to us, because I feel that it's a topic I've been passionate about for years and I've been trying to work away at for years. But it's making the change that is the important bit, and it's not much use if I just have a passion that doesn't translate into changing in practice and improving access for people like Debbie and people who are still homeless now. We have 1 minute left, so I wanted people in the room, for those of you who've been using the app, there's a section where you can write notes from any session you go to, and I would like you, just not necessarily this minute, but maybe when you leave the room, write down something in your notes just to say what you're taking home from this session, whether it's something powerful that chimed with you, whether it is something that you will change, that you will take back to your service, something that you'd like to go and learn about. And I don't know if there's anyone in the room who is prepared to put their hand up and say what that thing is for them. Yes, we've got somebody at the back. Run, lady with microphone. Uphill, stairs.
That job.
Hi, thank you everyone for speaking. It was really interesting. I think a take home for me, I'm working currently in an acute setting in a borough of North London where there's a really high rate of homelessness, people experiencing homelessness. And so one of my take homes is kind of seeing the holistic value of caring for people with homeless, especially on discharge. So some of the things I'm going to look up are some like community prescriptions. So yeah, to help on discharge for people like that, because oftentimes or the social worker will discharge them into hostels, and that's kind of the last thing we hear about them. Maybe they get 2 weeks paid or 10 days paid for in a hostel, and then they're kind of left to their own devices. So finding out whether it's day centres, whether it's some kind of rehab, just to give them options so that if they ever do, and like written things, so that if they ever do want to kind of take that jump or take that initiative to sort a part of their life out, that they can have the facilities and be empowered to actually make that step.
Thanks for highlighting acute care, because we've been more talking about community-based interventions, but it's so important to think about discharge, and we know that a lot of people are discharged onto street, even though that's not something that needs to happen these days. And the functional level required to sustain survival on a street is so much higher than is required to sustain survival in a warm house with family around you. So I suppose for anyone working in acute care, just think about that it's not just about being able to walk a short distance with a Zimmer frame if you're being discharged to street. Any other take-home messages before we finish? Oh, there's one over there.
Hello. Yes, again, I think it's about acute discharge back out into primary care. So we work on a busy ward, and quite often the conversation is, yes, you've had a patient staying with you, you've managed to gain that rapport and that friendly conversation. We enreach onto the wards, in fact, in our team. So we do have, I suppose I made an assumption that I had a good team that I could communicate with and say, this person is coming out. But I do, having been sitting here today, wonder whether or not, in fact, I didn't follow that patient out, or I didn't actually ask for the wraparound more, that I didn't follow them up more, that the equipment I gave them wasn't the correct equipment for them to deal with that very intense need to be functional back out in community, wherever they may have ended up. And that when we do discharge out, we're told to draw the line. They're going to present at the town hall as homeless, and that's all you need do. You need just forget about it after that, and it's just not good enough.
No.
It has to be wrapped around far more than that. So I think I need to be speaking to my managers then to say, okay, so what's the connection from our side, and making sure that a more senior person takes on the referral rather than leaving it to just the triages. Actually will probably focus on, this is a person that needs following up, thinking outside of the box, I think is where I'm going with that.
Brilliant, thank you. And yeah, be disruptive, ask more questions, challenge. I think that's the only way that people will be put on the spot to question whether somebody being discharged to the local council building to sort themselves out with a pair of crutches and a bag, that's not ideal if you've been very unwell for a long time in hospital.
Hi, thank you. Amazing session. My name's Darren Brown. I'm from London. Following on for this point of acute care as well, that we know that obviously within NHS policies, as has been mentioned, so the 20+5, inclusion health is actually part of that. And so some trusts do have inclusion health teams that specifically focus on people who are experiencing homelessness. So that can be a policy lever to lean on, so that you can make sure that you're providing that wraparound care when supporting people discharging from acute settings into whichever environment they're living within. So I think looping this all in, thinking about policy, thinking about needs, there might be an inclusion health team that can support with that. And maybe this is something that we can be advocating for, which is rehabilitation professionals being within inclusion health teams.
Absolutely. Sadly, though, it's a real postcode lottery, and even within London, there are only some hospitals that have inclusion health teams, and then outside London, some hospitals that have it. So if there isn't an inclusion health team or pathway team that are supporting people experiencing homelessness, let's try and make some champions who understand the problems and who can advocate for the issue of inclusion health, even if the paid teams aren't there. Thank you. I think we'll draw this session to a close, 5 minutes over. Thank you for your engaged commitment to this session, and I'm around tomorrow if anybody wants to have a chat. Thanks.
Thanks.
And thanks, Debbie.